The patient is a 33-year-old prominent art designer who has a clear medical history. The patient is highly dentally anxious, was traumatized by dental experience of an extraction of a lower right premolar in his youth. He has never seen a dentist since, and that was probably around 20 years ago. His chief concern was the severe pain on the lower right first molar, which was filled by another dentist with GIC, and the tooth became asymptomatic until of late. A dull throbbing pain has then been reported, often at night. On examination, the patient is of a skeletal class 2 profile with normal lower third facial height. There is a good range of movements with no pain, clicks, or crepitus from the temporomandibular joints. The patient is partially dentate with missing 4-5 and 3-6 with upper anterior crowding, but is proud of his appearance as it expresses his character. The patient has poor and neglected oral hygiene with large deposits of subgingival and supragingival calculus. Basic periodontal examination has been charted and scored as 3. He has a heavily restored lower right second molar, and that is the tooth of concern. Diagnosis involved caries and irreversible pulpitis on the molar tooth 4-6. The treatment plan options were listed in the write-up. The definitive and comprehensive treatment plan would first involve thorough and deep debridement with lots of supportive periodontal therapy. But of course, in the first visit, the ROP, relief of pain, was addressed, where symptoms and disease of the 4-6 was performed with an emergency dressing of pulp extirpation and pure leather mix, followed by cavit and a provisional restoration. The endodontic treatment of 4-6 is then performed 1 week later under rubber dam isolation. Working distance was determined by an apex locator. The treatment involved mechano and chemical preparation with copious irrigations of sodium hypochlorite and EDTA. Medicaments in between visits would involve leather mix and calcium hydroxide with a ratio of 50-50, and eventually the penultimate visit would be dressed with a full calcium hydroxide dressing and until the tooth is symptom-free. Coronal preparations involve extort ultrasonic tips and preparation towards working distance with pro-taper and rotary files were used. The technique of preparation was crown down and eventually will be sealed with gutta percha as master apical file and endorest sealant. The sealant is a radio-opaque resin methacrylate-based hydrophilic material that relies on chemical sealing rather than heat or pressure and is used with a master cone GP. In this case, there are 4 canals on the molar tooth. The master GP is then inserted and a passive apical tightness is felt. The sealant is left to be set around 20 to 30 minutes and the extra unwanted GP is then seared off. Less pressure and no heat equals to a lower risk of iatrogenic damage to the roots if compared to other conventional methods of obturation. The tooth has then been provisionally restored, its bite checked and adjusted, and left there symptom-free for a month before a crown and a core, a neocore material, is used to restore the crown definitively.